So very good evening everyone. Hope I am audible and visible. A very good evening everyone. So welcome you all to the recall session. So we'll be discussing the INI-CET November 2023 exam that was held yesterday. So we'll talk about the psychiatry recall questions. So I hope all of you are doing well. And again, disclaimer, before starting again, these questions which we are discussing are basically recall based questions, and again the motive is to get an idea of more actual questions, and you will get the final questions in the PrepLadder app. So let's start with the discussion. So before starting the question, again a brief analysis of the psychiatry questions. Now the feedback which we have got from the students, overall the exam level of the questions was moderate, but when we see psychiatry questions, I would say there was a mixed bag of questions of psychiatry, and this time in psychiatry there was a lot of overlap with the various subjects. So you will see some of these questions also being discussed in various other subjects. So what I've done is I've tried to take all these important questions. We've tried to dig in to try to find out all the questions of psychiatry which were asked. So the topics which have an overlap with psychiatry in this time's INI-CET exam. So you will see some overlap with the PSM, forensic, there was again some overlap, and psychopharmacology again very important. Even in the LRR session we have separately discussed psychopharmacology, and a chunk of questions was from pharma. So we'll discuss all those questions. Good afternoon Satya. And also OBG and pediatrics again is also, there are some overlaps. So yes, so we'll talk about this. So this is the list of the topics which were asked in the exam yesterday, and if you see again a chunk of the questions which were asked were from psychopharmacology. So we'll talk about these questions, and there was some question on substance. Again substance they've asked again, but the question was a bit off track. Good afternoon Ugandhar Adi, good afternoon. So there was an off track question again. Seeing the trend, they've been asking some off track questions from substance, and also one question on assessment, and also one question on POXO we'll talk about. So let's start with the first question. Now lithium again, and again we are talking discussing that lithium is one of their favorite topics. And good afternoon Atropine. So lithium is a favorite topic, and even in all our previous sessions we have been talking about this. So again a question on lithium. So please see the question and let's try to understand what the question is all about. A pregnant female again, so they have added pregnancy. Again we have been discussing pregnancy psychiatry. This topic is being asked again and again. So with bipolar disorder, with a history of previous 4 episodes, there is no episode for the past 1 year. So the patient is symptom free, maintaining well, and she is on lithium, 750 milligram of lithium, and now she is in the 3rd trimester and she visits the psychiatrist. So the question is, what is the next step? So can anybody tell me what will be the next step? What will you do? Will you increase the dose, decrease the dose, stop the drug and let her be drug free, or will you switch to valproate? So what are we going to do? Again very interesting. Again let's try to understand. So this again if you've seen the main videos, we have discussed this point in the main video as well. So lithium and given in the 3rd trimester. So let's talk about this again. Some of the questions which I'll discuss, many of the questions we have discussed in the main PrepLadder app videos. So let's talk about this. Let's talk about now, since we are discussing lithium, let's discuss all the important points. Now lithium and pregnancy, again all of us know that it is FDA pregnancy category D. Again there is a risk in especially in the 1st trimester, and there is evidence of human fetal risk, but again we see the risk benefit, and sometimes we give lithium even in pregnancy. We know it has a teratogenic effect, that is it causes Abstein anomaly. Incidence is 1 to 2 per 1000. It is 10 to 20 times. This risk is 10 to 20 times more than in general population, but the risk is lesser than valproate and carbamazepine. So many times we have discussed when we choose lithium and valproate, we can choose lithium in pregnancy. Of course we need to do fetal echocardiogram when we are giving lithium in pregnancy, especially in the 1st trimester. Okay, so I hope this point, this all of us know. Now let's talk about when we have to give lithium in the 3rd trimester. Again I am trying to discuss this so that again even for the future aspirants, even for the NEET PG, such questions come, because high chances are they're going to ask such questions. Let's discuss some of the important points of lithium and pregnancy in the 3rd trimester. Now when we talk about 3rd trimester, So when we talk about third trimester, so Dr. Gluteus, if the patient comes in the first trimester, and again we have to always in pregnancy we have to see risk benefit. If you think that we can stop lithium and we can give some other drug, then that is one thing we can do. And if you think that stopping lithium will be more of a risk, then we may continue, and then we monitor the patient with ultrasound with echocardiogram. Now let's come to the third trimester. In the third trimester, again there are 2 points. First is, in the third trimester there are physiological changes which occur in pregnancy which alter the maternal lithium pharmacodynamics, pharmacokinetics. And second point we'll talk about shortly before delivery what needs to be done. Now because of this change in the maternal lithium pharmacokinetics, such as there is increase in the glomerular filtration rate, there is increase in the plasma volume, there is increase in the renal tubular absorption. Cumulatively it is seen that the sodium retention is around 1000 milliequivalent. Now again when we talk about third trimester, it's it's not always that we have to increase the dose. It's very important to understand, yes, there is change in lithium pharmacokinetics, but we need to understand that lithium is a very notorious drug, in a way that it has a very narrow therapeutic index. So changing or increasing the lithium levels can have an effect on the increase in the lithium levels, and in fact it can lead to lithium toxicity. So it is very important when the patient is in third trimester. So we have given the history that everything is going fine. She comes in third trimester. It's very important. So again it has I've taken from all the latest textbooks. So the CTP says it is very important for fetal and maternal concentration are similar. So minimal effective dose should be given. So one should not jump into increasing the dose, because sometimes we get this idea that maybe that lithium levels may decrease because of change in the pharmacokinetics. But it is very important to understand that first of all we need to monitor lithium closely. So monitoring lithium closely would be the best answer. So this option is not given in the question. So we need to monitor lithium and see the levels. If we see that the lithium levels are low, then we may increase. Or if we see clinically it is important, or clinically it is found that lithium needs to be increased, then we need to increase. Nowhere in the question it is mentioned that there is any need of right now increasing lithium levels. So it is very important, don't jump up and increase the levels, because we know lithium toxicity again may be very difficult to manage in the patient. So it's very important. So don't increase. Better answer would have been we would monitor lithium. Now that is not given. Now let's continue further. Now we know that we cannot discontinue lithium, because any rapid discontinuation would have a high risk of relapse. Again this is a very important point, especially during pregnancy, in the postpartum period the risk of reoccurrence is very high. So discontinuing is not an option right now. So we know this much dose is maintaining the patient well. So dosage reduction may be considered, especially when we are approaching the delivery time. So then we may decrease the dose. So this is important. So in the third trimester we may decrease the dose. Now coming to shortly before the delivery. So when if they specifically, maybe next time they specifically ask this, that if the patient is approaching delivery, what to be done. Now again CTP says that reduce or possibly temporarily we may discontinue, because there is a risk of lithium toxicity in the fetus. So to decrease that risk we may reduce, or if possible we may stop. Again I am saying it's not always that we have to stop, if possible, because again we have to see risk and benefit. If you find that stopping will be more risky, patient is more at risk of reoccurrence, then we may possibly reduce the dose. So this is the concept. Now coming to the nice guideline, the Maudsley recent guideline, again what they have to say, again let's see what they recommend. Lithium plasma needs to be adjusted. This is very important. To maintain the plasma level we have to adjust. So adjust according to the levels, adjust according to the patient clinical profile, and should be within women's therapeutic range. And if we are during labor, it recommends that lithium should be stopped during labor, and plasma level should be checked 12 hours after her last dose. So this is these are some important recommendations in terms of lithium and pregnancy. So it's very important. I hope this is clear to everyone. So the answer of this question, let me come back to the question again. Will you increase the dose? No. it is not mentioned, or there is no reason for right now increasing the dose. Will you stop the drug and let her be drug free? No. Again, there is a high risk of relapse. Will you switch to valproate again? Patient is been maintaining well, and of course we know, lithium teratogenic effect would occur more in the first trimester. That has gone. And again, valproate, there is no use of switching it to valproate. So what will you do? So the best answer here would be decrease the dose. I hope this point is clear to everyone. Very important. Is it clear now? Since we are discussing this point, and again, since this topic is very important, let me just complete the discussion of lithium. Now after delivery, so after delivery, again try to re-establish the full prophylactic concentration again, as we discussed, because again the renal system will come back to the pre-pregnancy state, and there is a high risk of reoccurrence. So it's very important to re-establish. And coming to breastfeeding, now again they may ask you about breastfeeding as well. Again, you should be with caution, because we know that lithium is appears in breast milk. Again we have to see risk and benefit, and again it is seen that it is more beneficial of giving continuing breastfeeding rather than not continuing breastfeeding. So again, this is about lithium and pregnancy. I hope this is clear to everyone. A very important topic. Again, don't miss reading lithium. Any exam you are preparing, if you've seen the last so many exams, lithium is one very important topic, and nowadays they are integrating a lot of psychopharmacology with pregnancy. So this is one classic example in the question which was asked. I hope it is clear to everyone. Right. So again, this was something which we were predicting, but a slightly tricky question, you may say. But again, we have also discussed this in the video. Now let's come to the next question. Again, this is again a topic which was anticipated, which was expected to be asked, and even those who have seen the LRR video, TCA toxicity. This is again, you will see, if you see, the topics are not, again we always say in INI-CET, the questions may be different, but the topics get repeated. And if you see, this is a classical example. They're repeating question, they're twisting. In fact, we also discussed some new question. Here the question is different. So let's see the question. A patient was started on amitriptyline, some said it was mentioned, some said it was TCA, and the patient was found to be unconscious. Which of the following is not suggestive of TCA toxicity? So what is the answer? What is the right answer? Very good, Dr. Prabhat. Yes. The right answer. Again, if you see the LRR video, we have talked about TCA toxicity, a very important topic, and previously they've been asked a lot of time about the treatment. So let's see, TCA toxicity again, let's briefly discuss. So we know in TCA toxicity there are CNS, CVS and ANS system which are getting affected. Very good. Yes, Satya, it is C. So CNS, again, patient may have confusion, delirium. And this confusion, delirium, it occurs because of anticholinergic effect of the TCAs. And in fact, if the patient has dementia, so again sometimes such questions may be asked. If the patient has dementia, in dementia we know that the acetylcholine is reduced. So again the risk is further increased of symptoms such as confusion. So yes, confusion can be seen. Seizures again can be seen, which is in fact dose related. Seizures can occur, and patient can also land up into coma. Then again CVS effects can occur, arrhythmias and cardiac conduction defects can occur in the autonomic nervous system again. So we have, it has anticholinergic property. So mydriasis may be seen because of M3 blockage, mydriasis may be seen, and very importantly it is hyperthermia. It is hyperthermia. Why hyperthermia is occurring? Because of the blockage of the thermoregulatory sweating. So because of anticholinergic effect, the thermoregulatory sweating is reduced, is blocked, because of which hyperthermia is occurring, not hypothermia. So very important, please remember, these are some of the important findings in TCA toxicity. And we have already discussed treatment. Again, we do alkalization with the sodium bicarbonate, monitoring ECG again, because we have discussed arrhythmias can occur, and activated charcoal may also be used. So this was about TCA toxicity. So let's come to the question again. So what is the right answer? Let's discuss here again. So we know confusion can be seen, arrhythmias can be seen, pupillary dilatation, mydriasis can be seen. So what will not be seen in the patient? It will be hypothermia, because hyperthermia is seen. I hope this is clear. Again, you've been seeing a lot of such topics are getting repeated. Now let's discuss the third question. Again, I hope all of you have marked this question correctly. This is a previous INI-CET question, and this is one question which we also discussed in the LRR, and we discussed this question has a very high repeat potential, and in fact this was repeated. I hope this was the question. Please let me know if you have seen any other options rather than what I am discussing, so we can also edit the question. So the question is, all of the following are side effects more commonly seen with carbamazepine than oxcarbazepine, except, so which is less with carbamazepine and more with oxcarbazepine. So what is the answer of this question? Anybody, what is the answer of this question? So can you tell me what is the right answer? Again, we have discussed this question again in the LRR, we've talked about this. So yes, we know hyponatremia is more commonly, so we know the right answer is, it is a hyponatremia. Rash, blood dyscrasias, hepatitis, these are more common with carbamazepine. So let's just briefly discuss, let's discuss briefly. So carbamazepine and oxcarbazepine. So we know in carbamazepine, side effect, GI side effects such as nausea, vomiting, constipation, diarrhea, CNS side effects such as ataxia, drowsiness, these are in fact some of the most common side effects with carbamazepine. And in fact carbamazepine, you must have read that it has auto-induction. So over the course of time, patient becomes more tolerable to these side effects. Now more serious side, very good, Adi. Yes, it is B. More serious side effects, again one should know, such as blood dyscrasias, such as aplastic anemia, agranulocytosis. So this is one of the reasons we have been discussed. Can you tell me again, this question is a very high question, may come as a future question we have discussed. So because of this serious adverse effect, why carbamazepine is contraindicated with which antipsychotic? Can you tell me with which antipsychotic? We have discussed this numerous times. With which antipsychotic? C for carbamazepine, C for clozapine, because clozapine also causes agranulocytosis, and combination of clozapine and carbamazepine may be a fatal combination. So never use these two drugs together. Then some of the other serious effects such as hepatitis can occur, then rash can occur. Yes, Adi, very good, it is clozapine. Rash can occur such as Stevens-Johnson syndrome, such as erythema multiforme, then TEN can be seen. So rash can occur, and yes, hyponatremia can also, some of the other side effects, hyponatremia can also occur, and these are some of the side effects. Now let's talk about oxcarbazepine. Again, in oxcarbazepine, most common side effects are sedation and nausea. Now coming to, when we compare some of these side effects, it's very important to understand this. Again, when we talk about the blood dyscrasias, it is seen that these are not seen with oxcarbazepine, and in fact in oxcarbazepine we don't require any monitoring. So these hematological monitoring is not required. Even serious side effects such as rash, these are rare with oxcarbazepine. And in fact patients who have shown rash with carbamazepine, they are more at risk with oxcarbazepine. Otherwise oxcarbazepine again has rarely have these rashes. Now which is more common with oxcarbazepine? It is hyponatremia. Again this is very important, hyponatremia, which is more likely with the oxcarb than carbamazepine, and in fact it is seen in 3 to 5% of the patient. It is very important when you started a patient on oxcarbazepine to check the sodium levels, because many a times this hyponatremia may be initially very silent, and in severe cases patient may present to you with confusion or with seizures. So it's very important to remember this, that hyponatremia is more common with oxcarb. I hope this is clear. Again this is a direct repeat question. Again some of the questions may come like this. Now let's come to the next question. So again an interesting question. So in the psychopharmacology, mood stabilizers is a very important topic. So a patient on mood stabilizer has developed hyperammonemia as well as hepatitis. Some said there was raised hepatic enzyme was mentioned. So which is the drug which is most likely responsible? Can you tell me which is the drug? I hope this was the question and these were the options. So can you tell me what is the right answer here? Is it carbamazepine, valproate, lamotrigine, topiramate? So what is the right answer of this question? The right answer of this question is valproate. So the answer is valproate. Let's discuss. Yes, very good, Navdeep, very good. It is B, valproate. Now let's talk about some serious adverse effects of valproate. Let's just learn from the name itself. So L, let's talk about L. So L is liver. Now, moderate, effect may be that there may be increased hepatic transaminase that may be seen, but it's not that every patient having increased hepatic transaminase will lead to fatal hepatotoxicity. Now, let's talk about some risk factors since we are discussing these adverse effects, and many a times again, they may just repeat the topic and they may ask certain points about these serious side effects. Let's talk about that. Now, some of the risk factors for fatal hepatotoxicity, again it is very important to understand that that hepatotoxicity, fatal hepatotoxicity is in fact seen more in the pediatric population. In fact, the risk is more with when the age is less than 2 years. In fact, after 10 years it is hardly seen that it may be fatal. So please remember this, it is more seen in the pediatric population. Again, the risk is more when valproate is given with the phenobarbital, and if the patient has some neurological disorder, especially inborn errors of metabolism. And in fact, some of the patients with intellectual disability, so they may give you a picture of intellectual disability having some inborn error of metabolism on valproate. So again, such clinical picture may be given. So this is about liver, this is about the serious side effect. Now let's discuss some other serious adverse effects of valproate. Now P, you can remember from the name, pancreatitis. Again all these liver hepatotoxicity, pancreatitis, these are rare, not very common, these are rare serious adverse effects. So pancreatitis may occur, and one important point about pancreatitis which you can add on is that especially in the first 6 months of treatment, the risk is high. Now let's discuss some other serious adverse effect. Now A, ammonia. There is hyperammonemia. Patient can have hyperammonemic encephalopathy. And few points about hyperammonemia with valproate, 3 C's you can remember. Remember 3 C's when we talk about hyperammonemia. So what are these 3 C's? Please remember. Now it is more common when it is used in combination with carbamazepine. This is the first C. And patient may present to you with coarse tremors. So patient on valproate, with carbamazepine, with coarse tremors, okay, you may think of hyperammonemia, and treatment is L-carnitine. Treatment is L-carnitine. So remember these 3 C's about hyperammonemia with valproate. I hope this is clear. And one more serious adverse effect you can remember, again it can T. T is, it can cause thrombocytopenia, and of course we know it is also teratogenic. It is also teratogenic and it can cause neural tube defect. So I hope these are some important serious adverse effects. Please remember them. Again, if you've seen the pattern of questions, they recently, just before the exam only, they changed the setting of the, they made it into 4 blocks. So such changes are occurring, and if they want to repeat the topic, they may ask such question. I hope this is clear to everyone. These are the serious adverse effects with valproate. Now let's talk about this question. Again, we were anticipating, again, as we, if you've seen the LRR session, we were anticipating some questions on the treatment of dementia. Again, a slightly tricky question. In fact, this question I would say has a very high repeat potential. So again, such questions may get repeated. And slightly, there is a slight controversy, again not very but slight controversy. Let's talk about this and let's try to understand. An elderly patient with Alzheimer's disease unable to tolerate medication orally. So you've given some oral medication, he's not able to tolerate it, there may be symptoms, side effects with it. And the question is, which of the following acetylcholinesterase inhibitors can be used? I hope this is the exact question, or if anybody has any better editing, or you feel there was some changes, please let me know so that we can discuss this question. So the options are galantamine, donepezil, rivastigmine, memantine. We know memantine is a it's an NMDA antagonist, so it is out of the picture if they've asked you specifically acetylcholinesterase inhibitors. Okay, so we know this is not there. So basically, again we know in the treatment of dementia, let me just briefly again recapitulate the treatment. So we know there are acetylcholinesterase inhibitors and memantine, which is an NMDA antagonist. Very good. Okay, rivastigmine, good. So acetylcholinesterase, we know tacrine is not used, again it is not used these days because we know it is hepatotoxic, and 3 drugs acetylcholinesterase are donepezil, rivastigmine, galantamine. And there are some recent new advances, we have talked about this a lot, aducanumab and lecanemab. These basically are monoclonal antibodies. These are used as IV drugs, and they target the A beta deposit. So they are specifically used for Alzheimer's dementia. Okay. Now few more points. Very good. Yes, it was toxic. Tacrin. Very good. Now just few points before coming to the question. You can again, rivastigmine, galantamine, usually they are used for mild to moderate cases. Donepezil also for is mild, moderate, and even for severe. It is approved for even severe. It is only acetylcholinesterase which is approved for severe. And NMD antagonist, it is used for moderate to severe cases. While these drugs, the new drugs which have been approved, these are used for mild cases, for mild Alzheimer's disease, or even for mild cognitive impairment, MCI. So these are some points you may remember. Now let's talk about the GI effects. Now there are 2 points about the GI effects which I want to emphasize. The first is that the GI effects, these adverse effects, they are more with the rivastigmine and galantamine than donepezil. This is the first point. Okay, so had it been that if you want to change, suppose patient is on rivastigmine, galantamine, any of these might have mentioned, they would ask you change to which other acetylcholinesterase, then you would have answered it donepezil. Now if the patient is not able to tolerate because of these GI side effects, so orally we cannot give, so let's give with some other route. So we have transdermal patch, and rivastigmine is available as a transdermal patch. Okay, so the answer is rivastigmine. So what is the controversy? The controversy is, again, the books have not updated. Maybe in the coming editions it will be updated. So even now we have donepezil, which is also now available as a transdermal patch. But some of the the latest editions of books such as CTP, Maudsley, they mention about rivastigmine transdermal patch, but I think in 2022 donepezil transdermal patch was also approved. So this is the slight controversy which I was telling, but again, if you follow the books, then the answer becomes rivastigmine. Okay, again, this question may get repeated, such questions, because slightly newer questions, they may get repeated like this. So please remember. I hope this is clear. Now let's talk about this again. This question we have talked about again in our LRR session. A 30-year-old male presents with altered sensorium and pinpoint pupil. Which is the poisoning you will suspect? A very simple, direct, straightforward question. We know in which one of the which poisonings we have talked about. Can anybody tell me what is the right answer of this question? So we've talked about this again and again. So they're just twisting the language. Sometimes they tell that the surgeon is giving a medicine and there is a respiratory depression. And so this question is being very good. So the answer is, it is morphine. Okay. Okay, so if opioid is in the question, so the answer would be opioid. Okay, so morphine or opioid. So I hope this is clear. We know we have discussed this. Very good. So opioid was there in the, so thank you very much everyone. So yes, if opioid was given, then that would be the answer. So we have talked about this opioid intoxication. We have discussed this triad of respiratory depression, pinpoint pupil, and coma. And also we have talked about previously, a lot of questions have been asked on the treatment. So the treatment is, we know it is IV naloxone. I hope this is clear. Again, simple, direct repeat. And of course, we know that cocaine, amphetamines, these are stimulants, they cause mydriasis. And even dhatura, again, it has anticholinergic property. We have just discussed previously in TCA toxicity also, anticholinergic, it will cause mydriasis. Okay, I hope this is clear to everyone. Nowadays a lot of, so this is what integration is all about. They are giving a question, and they're they are put asking some core pharma from that. So this is how they are trying to integrate questions of various subject. I hope this is clear. Now let's talk about this question again. This is a slightly off track question again, but if you see in the main videos at the PrepLadder app, we have discussed this in detail again. So let's talk about this. So we have 4 statements. One is so these statements are basically about stages of change. So let's first discuss the stages. So again, we have talked about this in our PrepLadder app video. So again, so let's talk about these stages of change. So basically it is the trans-theoretical model of change which is given by Prochaska and De Clemente. So anybody who desires to change, whether it is, you know, someone is taking substance, he wants to quit substance, anybody he wants to change any habit, so again they may pass through these stages. So what are these stages? The first stage is the stage of pre-contemplation. Again, as the name suggests, pre-contemplation means the person does not see any problem in the behavior. So patient consuming alcohol says, oh, I don't have any problem, why should I stop taking alcohol, I don't take alcohol too much, I don't think so. So there is no intention of changing only. So this is pre-contemplation. Second is the stage of contemplation. Contemplation, now the patient realizes that there is a problem. So patient, you know, again this patient who is consuming alcohol says that yes, I think that I am having this problem, I am drinking alcohol excessively, and he considers stopping his behavior, but right now there is no commitment for action. He wants to change, but there is no commitment to action, so he is contemplating. So just see the names, you will understand. Again, in psychiatry, just see the names and you will understand. Now next is he is in the preparation phase. So again, as the name suggests, now the person intends, so he is intending to stop the behavior and he starts making a plan. So now he is preparing. So you know, this patient consuming alcohol, now he may visit a psychiatrist, or you know, visit someone who has all, you know, stopped alcohol, and you know, takes advices and tries to formulate a plan. So this is preparation phase. Next stage is action. Again, as the name suggests, now he stops the behavior and start making those changes. So this is action. And lastly, maintenance. As the name suggests, maintenance, he is now maintaining this, you know, behavior. So now for a few months or maybe for a few years, he is not taking that substance, or he is not doing that behavior. So these are the phases of change, and any time during, you know, these stages, patient may land up into relapse. Okay, so sometimes, you know, patient coming into preparation phase then may relapse, in action phase may relapse, even with maintenance phase may relapse. So again, then we use relapse prevention strategies to help the patient. Okay, so these are the phases. Let's now understand this question. So the option A is pre-contemplation. It says, means, so example, a person who smokes is considering to quit. So is pre-contemplation about this? No, in pre-contemplation he is not thinking about changing the behavior. So this is wrong statement. Option number 2, contemplation, a person is considering to stop, you know, to start morning walks because of its benefit to the health. Yes, now he is, you know, considering, he is contemplating. Yes, this is correct. So 2 is correct. Third is maintenance phase. A person has quit smoking for 1 year and has not smoked since then. Yes, so he is maintaining, you know, this behavior. So this is, yes, maintenance, this is correct. Action phase, a person with obesity says he can't do anything as it runs deep in the family. So he's in the pre-contemplation phase. So this is also wrong. So what are the correct statement? We know 2 and 3, they are the correct statement. So the answer is option B. 2 and 3 are correct. I hope this is clear to everyone. I hope this is clear. Many times just see the names and you will understand when you see pre-contemplation, contemplation. So just see the name. Sometimes, you know, if you read these, you know, topics before and you see the question, many times you are able to figure out the answer. I hope this is clear to everyone. I hope this is clear to everyone. Now let's discuss this question again. This question may have certain overlaps with the, you know, some of the other subject, but again I am discussing this because, you know, again, you know, in our PG days and even, you know, nowadays we sometimes use this. So let's talk about the heads assessment. So again, this is a overlap again. So can you tell me, so I've, you know, tried to find all the possible options. I've given you, you know, these 5 options. So the question is, heads assessment is used for which age group? Options are neonates, infants, under 5, adolescents, adults. So what is the right answer? The right answer is, again, you know, such questions, you know, INI-CET is asking. So the answer is D. It is used for adolescents. So let's talk about, you know, this heads assessment. Basically, you know, we try to inquire or identify risk factors and protective factors in adolescents. So, you know, risk factors which increase likelihood of certain risky behaviors, and protective factors which increase the ability to cope with stress. So we try to, you know, when we interview an adolescent, sometimes we try to find out these factors in the adolescent using the heads assessment. So let's discuss briefly. So what is this heads all about? So first is home. Again, a protective factor may be like patient has the adolescent has a good or a positive relationship. A risk factor may be that he has negative relationships. E, again E can be education. Again education, he protective factor, maybe he has positive attitude towards education, he's involved. Or negative factors or risky factors maybe that he's isolated, he is having very negative beliefs about this. So E is education or employment. A is activities. Again activities, how much he's involved, religious activities, if communal work is present. So these are protective factors. If he's having risky behavior, or if he has inadequate sleep, such activities may be risky behavior. Then is there any use of drugs or associated conditions with the patient? Then S, 3 S's there are. One is sexuality. Again, whether the person is involved in unprotected sexual intercourse, whether there is any history of sexual abuse, so that is sexuality. Then next is suicide, depression or self-image. So here we try to see whether patient has healthy coping skills, or patient has suicidal thoughts or depressive symptoms. So these are the things which we check. And last is S is safety. So whether the person he has access to weapons, or he does not use protective gears, for example while riding, does not put a helmet. So we see the safety. So this is the heads assessment which is used for adolescent. I hope this is clear. So the answer of this question is, it is for adolescent. Now the last question which we are going to discuss, again a bit of forensic psychiatry. And again this question in fact is before INI-CET. A similar question was asked in AIIMS before, and we have also discussed this point in our PrepLadder main videos. So let's talk about this. A 13-year-old female girl, she comes with her mother with complaints of abdominal pain. On examination, the urine pregnancy test is positive. As a medical officer, what is the next step? So what will you do? What is the next step what you are going to do? Again this is very important. This is related with the POCSO Act. So POCSO Act is the Protection of Children from Sexual Offences Act 2012, and there are some amendments in 2019 also, and we have discussed this. So whenever any such crime against a child that is less than 18 is done, again so it is a gender neutral act. It can be male, it can be female. So we have got a female, she is 13 years and she is pregnant. So what are you going to do? You're going to inform either the special juvenile police unit or the local police. This is the first thing which you're going to do. So this is the answer. Again a similar question has been asked previously in AIIMS. So again you will see topics do get repeated. So again this is the answer. I hope this is clear to everyone. So these are some important questions which we could get from the recall. If there is any other question, you can always message us, in this video, or you can also put it in the PrepLadder exclusive club on Facebook, and we'll try to answer the question. So thank you everyone, and best wishes for the result. Again 1 or 2 points I would want to tell you, that INI-CET exam is over. Okay, now let's get over with it. And few things which we can take it from the INI-CET exam is, first is you have got a good exposure of a real exam giving scenario. So use this opportunity. Also try to identify your strengths and weaknesses, and subsequently apply them for the upcoming a very important exam, that is the NEET PG exam. So thank you very much and all the very best. Again as I always say, keep smiling, keep moving forward. Thank you. नहीं मैं तो फिर जाऊँगा। नहीं कहीं जाके खाएंगे। नहीं